The benefits of using cognitive behavioral therapy as an anger management technique. Anger is a widespread social problem with serious consequences and implications for members of society. Anger is often manifested in acts of terrorism, child abuse, marital dysfunction, spousal abuse, an escalating incarceration rate, racial tensions, and epidemic rise in drug abuse. Anger has many degrees and many triggers which vary from person to person. This research project focuses on anger as it pertains to cognitive function intervention changes, which can be used to reduce anger levels and reduce destructive behaviors that negatively impact angry people's lives. Negative anger responses impact all areas of society and are often the causal factor in crimes and behavioral patterns which result in harm to others. From road rage to domestic battery to murder, anger is often the impetus for harmful behavior. The research question is, can cognitive-based anger management interventions be used to reduce anger levels? The hypothesis is cognitive behavioral therapy can be used to reduce anger levels when interventions are effectively applied. Both pre- and post-test results are based on responses to the National Anger Management Association's classification tree method of assessing anger. This method addresses both cognitive and interactive anger expressions. Some respondents showed greater progress than others after interventions were enacted and were fully engaged in the project with good motivation. National Anger Management Association notes that motivation to change is the most compelling factor related to positive change in the anger management process. The project objectives were to reduce anger levels in a Likert-based test scale ranging from 1 to 5 in levels of intensity for each question. There were 27 anger-related questions in the pre-test and post-test. Lower raw scores indicated that interventions were effective. Raw scores range from 0 to 70 in intensity levels, with 0 being the mildest score, while scores of 70 and above indicated severe anger issues. 5 sessions were scheduled focusing on insinuating the positive, putting anger on hold, maintaining a calm demeanor in stressful situations, responding rather than acting rashly and considering positive solutions. Each of these was an issue in the National Anger Management Association indicated as having a significant role in anger management. Additionally, characteristics related to anger problems were addressed at weekly sessions. These included frustration and tolerance, critical reactions, perfectionism, dysfunctional thinking, possessiveness, poor communication skills, punitive or punishing behaviors, addictive personalities, and using anger as a power tool in relationships. Each of the 5 sessions were followed by a video presentation about the behaviors. Each session lasted approximately 1 hour. Results indicated that these cognitive-based interventions have positive effects on behavioral patterns of respondents. Each participant who completed the sessions experienced a decrease in raw score totals on post-test. These findings coincided with the findings of other researchers who embrace the perspective of cognitive behavioral therapy can be used to address excessive anger issues effectively in group settings. Topics were discussed each week during the 5-week intervention training period as follows. Week 1, low frustration tolerance in judgmental and critical reactions. Week 2, perfectionism and all or nothing thinking. Week 3, possessiveness and poor communication. Week 4, punitive behavior and addictive personalities. Week 5, using anger as a power tool. Review of all concepts. The purpose, methodology. The purpose of this research was to assess the anger levels of research participants who self-identified as having excessive anger issues and to formulate effective treatment interventions in group sessions which would reduce anger levels. Pre- and post-test scores were obtained and compared to assess the effectiveness of the interventions. 7 respondents participated in the research project, which lasted for 5 weeks. The mean age for the respondents was 33 years. 4 of the participants were African American, 1 respondent was Hispanic, 2 respondents were Caucasian, 4 respondents were employed, 3 were unemployed. All of the respondents were voluntarily enrolled in the counseling sessions for anger management. Consent forms were required for all participants, and all participants were informed that they could withdraw from the research at any time. It was emphasized that all participation was confidential and the sessions would be held at a time when other people were not in the church for the sake of anonymity. Participants were informed that they would take the pre-test and post-test and that the instruments would be destroyed at the end of the project. Validity was an issue because the type of test allows respondents to self-report, and it is a qualitative type test, which lends itself to a personal interpretation as is reported by the respondent. Qualitative studies offer an advantage in that they examine the constraints of everyday life and capture the individual's point of view and allow for creativity and personal interpretation. However, qualitative studies often do not meet the more rigid standards of qualitative research, where analyzation of empirical materials from the crux of evidence-based research. No ethical issues surfaced during the conducting of the research, and no one withdrew from the participation. An A/B single subject design was used in the research. After segregation of results, charts and graphs were used to report findings. On the related graphs, A is the baseline phase and B represents the intervention phase of the pre and post test. Please review graphs. The test uses empirically validated and clinically proven concepts to assess anger and psychologically pathology. Interpretation guides and raw score guides and an interpretation table are part of the assessment systems. Raw scores are interpreted as follows. 0 to 39 are considered low scores, 40 to 49 are considered a mild score, 50 to 69 are considered a moderate score, 70 or above are considered severe scores. For the purpose of anonymity, each test was color-coded for each of the 8 participants in the group. Results. The mean score of the pre-test group was 67.14. The mean post-test score for the group was 51.42. Some participants benefited from the sessions more than others. The researchers was pleased to know that all participants had lower raw scores on the National Anger Management Association post-test. Using the criteria National Anger Management Association has established for determining severity levels of anger as a whole, the group scores declined 15.72 points. While both scores are in the moderate range of 50 to 69 points, it can be noted that the decline is significant because the pretest score of 67.14 was only 2.86 points from being in the severe range of 70 points. Resultant decline in the raw scores from 67.14 on the pretest to 51.42 on the post-test indicates that the group scores were only 2.42 points from being in the mild range of severity, which begins at 49.0 points. Conclusion. Research indicates that the cognitive behavioral therapy is of the great benefit for those experiencing anger management issues. This result supports that conclusion. And references are as follows.